You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for December 9th, 2022, this week. Nudges. AI, less is more in the ICU, myocarditis, exercise as medicine, and a closing note about December in the hospital. Now, first up is statin prescribing. JAMA Cardiology has published an interesting cluster randomized trial that evaluated the efficacy of nudging doctors and patients to prescribe statins. Now, first a bit on nudges. Harvard Law professor Cass Sunstein has made nudges as a policy instrument famous. For instance, the grand idea is that a nudge is a liberty-preserving approach that steers people in particularly beneficial directions. For instance, like having an opt-in to a job savings program already checked as a default. That way, you don't have to opt in, you are already in and you're saving money. Yet, not everyone is convinced. Behavioral economists have pointed out some downsides. For instance, nudges to encourage low-calorie milk consumption may have the undesired effect of increasing both low and high-calorie milk consumption. I'll link to a study there. So I'm not sure about the concept in general, but here was the idea that primary author Sinath Adesumali and colleagues at the University of Pennsylvania had. Their idea was statins reduce cardiac events. We know that, but most people who qualify by 10-year risk aren't on statins. Now, one reason is inertia, both doctors and patients' inertia. And another idea is that the electronic health record allows for an easy way to do e-prompts. And doctors love ratings, right? We love our scorecards. So this group at UPenn designed an active prompt in Epic telling doctors they should prescribe a statin for this patient with a greater than 10-year 10% risk. Then they showed a doctor a scorecard on how they stacked up with their peers. The authors also gave patient nudges by text message. However, only a third of patients consented to getting a text from the health system. Now, what I love about their idea is that they didn't just institute this good intention policy, say like the hospital readmissions penalty program. They studied it in a cluster randomized fashion in 28 primary care practices with 158 clinicians and more than 4,000 patients. They had a control group, and control group was standard care. This is the way to do policy. Don't just foist it on already overburdened patients and doctors. Study it. And what they found is that the nudge worked, sort of. In the main adjusted analysis, relative to usual care, the clinician nudge significantly increased statin prescribing alone by 5.5 percentage points. That was significant. And when it was combined with the patient nudge, it was effect size was even larger, 7.2 percentage point increase. Now, the patient nudge alone did not significantly increase statin prescribing relative to usual care. And again, remember, only a third of patients accepted the nudge. And the problem, though, the maximum absolute statin prescribing was only 15% in the clinician plus patient nudge group. The authors described 4 take-homes of this study. One was that the dual nudge had the biggest effect size. The clinician nudge also worked, albeit with a smaller effect size. They also felt like the fact that the active nudge had clinician input may have helped its utility, and they say this because adoption of this nudge was a little better than previous studies had shown. And finally, they concluded that the patient nudges alone were not effective. And so my comments, again, kudos to the authors for having the humility to study their good intention policy. And my view of statins has changed over time. I'm now convinced that the reduction is real and it's cumulative, but I see our role as advisors, right? Tell people the numbers, use clear communication, and let people decide. There is no way that statin prescribing should be a quality measure. We should not browbeat patients into good health. Some will want to do everything they can to reduce cardiac risk, and they'll feel that the disutility of taking a pill every day is worth the 25% relative risk reduction, but other patients won't. Now, if you liked quality measures, I don't, but let's say you liked quality measures, you could measure the quality by asking patients how they decided to take a statin. That to me is more important than whether they took it. And positive points would be that my doctor showed me my 10-year risk and I found that the risk reduction was convincing. And negative points would be my doctor said I had to take this because my cholesterol was high. Again, I remain shocked at how few patients that I have this discussion with have not been shown their 10-year risk and their risk reduction with statins. Okay, final comment. Studies of policies like this are a really good start. Statin prescribing, though, is a surrogate endpoint, right? What you want to know is if the policy leads to better health, better outcomes. And it's not a guarantee. Like I led with, nudges can have unintended negative outcomes that might negate the positive of more statin prescriptions. For instance, what if the time spent distracting clinicians with yet another yellow box and Epic and another dashboard detracts from the time that could be spent discussing things like exercising every day that you eat or not eating veggie straws in front of the TV? Nearly all policies, I feel, ought to ultimately be studied for better health outcomes, lest you end up with something like the hospital readmissions penalty program that might actually increase mortality, and I'll link to a paper on that. All right, second topic, artificial intelligence, chest x-ray, and cardiovascular risk. Now, the headline of this paper said, quote, a single chest x-ray could predict 10-year cardiovascular disease risk. And this was the lead paragraph of the news story. Quote, a single chest x-ray could predict a patient's 10-year risk of dying from a heart attack or stroke, say researchers who presented the results of their deep learning model at the Radiological Society of North America annual meeting. Okay, so the researchers used about 150,000 chest x-rays from a PLCO screening trial of prostate, lung, colorectal, and ovarian cancer screening. They trained a deep learning model and compared its ability to predict risk to the standard equation, like the pulled cord equation or the ASCVD risk equation that uses just basic clinical features. This one, you can calculate 10-year risk in about 45 seconds at the bedside with a patient. And the results of this AI chest x-ray program was that it was about the same. And even in a subgroup of patients eligible to receive statins, the performance of the machine learning algorithm of chest x-rays had a C statistic of 0.64 versus 0.6.5 with the equation. And remember, 0.5 C statistic is just a coin flip. So brief comments here. Gerd Gigerenzer is a German psychologist who's famous for his work in the heuristics of decision-making. You should be familiar with his work. It's amazing. Especially the famous experiment where doctors failed basic specificity and sensitivity questions regarding what mammography can predict. Now, I'm going to oversimplify one of his concepts, but it's that when there is uncertainty, fast and frugal algorithms are just as good, if not better, than complicated ones. And I think this is a classic case. Every single model that purports to predict CV risk must pass muster against the fast and frugal risk predictor equation that you can do in the clinic in 45 seconds. For instance, that famous gene risk score studies are really no better than just basic clinical data for CV risk prediction. And here, a super fancy AI model using a chest x-ray was no better. Use the clinical data and the equation, I say. By the way, this is also the best argument for CHA2DS2-VASc, yet I think CHA2DS2-VASc is right to be overturned by some more relevant risk scores. Now, the second reason to mention this abstract is that I'll always be on the alert for artificial intelligence hype. I'm a huge proponent of AI. I'm sure it will improve care in some situations, but CV risk prediction is likely not going to be one. Okay, third topic today, the box trial. Now, to become a cardiologist in Denmark, you must first earn a PhD. Let that sink in. This was one of the many stunning revelations I learned during my visit to Roskilde in the spring. Now, this is the likely reason so many great trials come from Denmark. Cynics would say it's because Denmark forces young people to do research, but I think it's more likely that the policy has sort of inculcated a positive scientific culture in the country, and you really feel that when you visit. Now, one of the more impressive but least noticed trials from AHA was the box trial of multiple interventions in survivors of out-of-hospital cardiac arrest. This trial had a 2x2 factorial design to study the use of two different blood pressure targets, a mean arterial pressure of 63 versus a mean arterial pressure of 77, and two different arterial concentration targets, a restrictive one from 68 to 75 millimeters of mercury, or a liberal one with 98 to 105 millimeters of mercury. And within that trial was yet another subordinate trial of duration of fever prevention, either 36 or 72 hours. All of these questions remained a matter of debate before the trial. And of course, when there is equipoise, the answer is not eminence or what is plausible. The answer is always randomization. About 800 survivors of cardiac arrest were randomized at multiple big hospitals in Denmark, and New England Journal of Medicine published all three papers. In the oxygen study, first author Henrik Schmidt, there were no significant differences in the primary outcome of death or disability. Hazard ratio was 0.95. The finding was very similar to the HOT ICU trial, another Danish-led RCT that found no differences in outcomes with a restrictive oxygen strategy. So less oxygen was not different. ICU docs are probably not surprised, but I have to say it is a bit counterintuitive. In the blood pressure part of box, also published in New England, first author Jesper Kierkegaard, there were no differences in the primary outcome of death or disability with either the MAP target of 63 or 77 millimeters of mercury. Hazard ratio here was 1.08. Now, observational data had suggested that the MAP that should be used to secure flow in a post-anoxic brain is at least 75, whereas guidelines suggest that the mean arterial pressure should be maintained above 65. But here we now learned that a target of 63 is the same as a target of 77. This is obviously important information because the extra effort it takes to keep the MAP up, say with pressors, does not lead to better outcomes. And finally, in the duration of device-based fever prevention study, also published in New England, first author Christian Hassiger, there was no difference in the primary outcome of death or disability in either the 36 hours of fever protection versus 72 hours of fever protection. The hazard ratio here was like 0.99. Now, recall that this podcast has also covered the TTM trials, which found that basic fever prevention strategies were similar to lower temps, and that was for the early hours to 1 day. These trials studied the use of fever prevention with a cooling device and found doing it for shorter time was as good. Now, my comments. I don't work in the ICU that much. You probably don't either. But these trials are worth studying because they show a method of thinking that is incredibly valuable. The question of oxygen and blood pressure targets and duration of fever prevention were each debated before the trials. And of course, when there was once eminence, now there is evidence. This is our path forward in so many areas of medicine. Now, in my critical appraisal lectures, I start by saying that not everything in medicine can be studied in an RCT, and not everything needs to be studied in an RCT. For instance, kindness, listening, empathy, compassion, these need not be subjected to randomization, but a heck of a lot more of what we do ought to be tested in trials. Now, perhaps this is the culture of science in Denmark that pushes these groups to have a thinking framework in which they study important questions. Whatever it is a model to which more health systems should strive for. My second and final comment that strikes me, in each of these trials, less was as good as more. Lower oxygen and blood pressure targets, shorter duration of fever prevention, all performed equally well to the targets requiring more intervention. Well, perhaps there is a pattern there too. Of course, there are times when more care is obviously better. But when in doubt, I wonder if the Bayesian priors ought to favor the less intense strategy as a matter of default. Now, congratulations to the Danish group involved in Box and to my friends who have the opportunity to visit the Danish health system. I would take it as it was such an eye-opening experience. All right, next topic, myocarditis. In the last few weeks, there were papers. A German group of pathologists report in the journal Clinical Research in Cardiology, I'll link to it, quote, standardized autopsies were performed on 25 persons who had died unexpectedly and within 20 days after SARS-CoV-2 vaccination. In 4 patients who received the mRNA vaccination, we identified acute myocarditis without detection of any other significant disease or health condition that might have explained the unexpected death. End quote. In JAMA Pediatrics, a meta-analysis of 23 observational studies, 854 patients with SARS-CoV-2 vaccine-associated myocarditis reports that the incidence was greater after dose 2. The mean age of patients was 16 years, and men were 10 times more likely to be affected than women. This paper reported that 92% of these young people with this condition were hospitalized, 23% required ICU admission, the mean hospital stay was about 3 days, and 15% had left ventricular dysfunction. The authors called these largely favorable early outcomes in adolescents and young adults. Jack has published an observational study comparing the outcomes of patients who had viral myocarditis in the 20 years before the pandemic to those who had vaccine-induced myocarditis during the pandemic. So I'm not going to say much about this study, but if I were giving awards for the most dubious non-randomized comparisons ever published in an observational study, this paper would be competitive. Okay, my comments on these 3 taken together. Myocarditis is a common condition that electrophysiologists deal with. That's because things that inflame the heart and then cause scar often lead to arrhythmias such as VT, VF, and sudden death. Next topic is exercise. Now, I work in Kentucky. We are one of the least healthy states with some of the highest rates of obesity and obesity-related diseases. Most of my patients are either sedentary or they're severely under-exercised. So I've been trying this new plan, the Mandrola plan. But first, let me tell you about an observational study using the UK Biobank, which is a sort of longitudinal prospective data source that follows mostly healthy volunteers over time in the UK. One nice thing in this study is that the volunteers in this study had accelerometers that objectively measured physical activity. The European Heart Journal published this analysis. The first author is Matthew Amati, and this group studied the association of very short periods, a few minutes of vigorous exercise and mortality. They had a follow-up of about 6 years, and they found a dose-response curve for, say, no physical activity, 0 to 10 minutes of vigorous physical activity, 10 to 30, 30 to 60, and greater than 60 minutes. And these were all per week, minutes per week. The optimal dose, the nadir of the curve they found was 53 minutes per week. That's about 7.5 minutes of vigorous physical activity per day. The minimal volume dose, that is 50% of the optimal dose, was about 15 minutes per week, and that associated with an 18% reduction in all-cause mortality. The authors conclude that these findings suggest reduced health risks may be attainable through relatively modest amounts of vigorous physical activity that can be accrued in short bouts across the week. Okay, I know you know the deal. Studies like this overflow with limitations. The big one here is reverse causation, meaning it wasn't the exercise that caused better survival, it was the fact that healthy people who survive longer are more likely to do vigorous physical activity. Also, the UK databank is also known for healthy people's bias, so these may not be representative of people with challenging social and economic conditions. Nonetheless, my friends, I'm trying this experiment of explaining to people the benefits of even short periods of consistent physical activity. I'm saying, look, do 10 to 15 minutes a day is a heart pill. It's a heart pill. Take it every day. Be consistent. Now, some patients have already come back with good results. The key here is that you aren't prescribing a personal trainer or gym membership or half marathon training program or CrossFit. You're simply saying do something physical and sustained for even a short period, but do it every day. It's a heart pill. Okay, finally, a closing note. Now, I wonder if your hospital is like ours. In the U.S., December is always stressful because people have met their deductibles and they want to get their surgeries or procedures before the new year. And of course, that rush combines with the respiratory virus season, and this year has been especially tough. Not so much with COVID. Fortunately, the COVID pneumonias of 2020 and 2021 are thankfully almost gone, but gosh, we have a lot of older and vulnerable people with all manner of respiratory viruses. And then, of course, these patients get AFib and VTE and oodles of other medical complications. But I see a positive side. The positive side of this stress is that you feel extremely useful, right? Even subspecialists like electrophysiologists feel useful because we come in and help people with their AFib. As I've said before, medicine is most pure when we are helping people who are asking for our help. And in December, in the U.S., there's a lot of people who need our help. I think at its core, we've all picked a meaningful and important job, and this time of year really highlights that choice. Okay, that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, friends, please, if you like this podcast, take the time to give us a rating, write us a brief review. Even a sentence or two goes a long way to helping others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.